start by reviewing some basic antimicrobial principles. We tend to talk about antibiotics as either bactericidal or bacteriostatic. If you wanted to make a general statement here, it turns out that most antibiotics are bactericidal. And one of the reasons is because the largest group of antibiotics are the cell wall inhibitors, and all of our cell wall drugs are bactericidal. We only have a couple of groups that are bacteriostatic. Most of our protein synthesis inhibitors, in fact, are bacteriostatic, and of course there's going to be one exception to that. When it comes to using antibiotics, the rule is we use them one at a time. Rarely are we going to use combinations of drugs. There are times when we use a combination and we can get an additive or perhaps even a synergistic effect. We'll talk about two specific examples of synergy. The most famous really is the combination of penicillin plus aminoglycosides. We'll see this combination used for certain bacteria that are more difficult to kill with a single drug. Occasionally we'll run across combinations like penicillins plus tetracyclines that actually antagonize each other and are never going to be used. Many people want to know exactly how to organize antibiotics. This is a section that a lot of people struggle with, just simply organizing the material. I strongly suggest that you organize antibiotics according to their mechanism. This table does a nice job of that. It summarizes the four major groups by mechanism. So notice that would be cell wall inhibitors, protein synthesis inhibitors, nucleic acid synthesis inhibitors, and folic acid synthesis inhibitors. And that's the way you want to break down these drugs. The cell wall drugs are the largest category and include drugs like penicillins and cephalosporins. There's a number of protein synthesis inhibitors you see listed in the table. When we get to that part of this chapter, we're going to break down the protein synthesis inhibitors by 30S or 50S as a target. The other drugs, they're just smaller in number. When you look at the inhibitors of nucleic acid synthesis or folic acid synthesis, but important nonetheless. One of the challenges with antibiotic use is the development of resistance. We know that resistance is a major problem, perhaps because of overuse of antibiotics or overprescribing. When it comes to your Step 1 exam, it's very popular to ask some resistance questions. I've highlighted specific resistance mechanisms on this table that we can discuss right now. First, for penicillins and cephalosporins, it's the production of beta-lactamase enzymes. You remember that these groups of antibiotics are called beta-lactams. They have a four-membered beta-lactam ring that must remain intact in order for these drugs to work. It should be obvious then that if the bacteria produces beta-lactamase and that enzyme can cleave this ring, these drugs will be ineffective. There's also a couple of other mechanisms of resistance for pens and cephs. You can change the target. In fact, this is the most common type of resistance for you to predict that can occur. If the organism changes the target for the antibiotic, that's a way to develop resistance. So you ask, what is the target for pens and cephs? It's penicillin-binding proteins. So the bacteria modify their PBPs, and these drugs don't bind effectively. The third mechanism we'll talk about is change in porins, and this affects the entry of the antibiotic into the bacteria. A second mechanism, when you look at macrolides, resistance can develop when the bacteria produces methyltransferase enzymes that alter the binding of the antibiotic. Basically, it becomes methylation of the binding site that prevents the macrolide from binding to the 50S ribosomal subunit. For tetracyclines, it's an active efflux pump that is the mechanism of resistance. Essentially, when the tetracycline enters the bacterium has a mechanism to pump that drug right back out of the cell and prevent it from concentrating. And that's how you get resistance. For sulfonamides, it turns out that the resistance mechanism is due to the fact that sulfonamides are PABA analogs. So the bacteria will increase their production of PABA to outcompete the sulfonamide. This is a mechanism that we'll talk more about as we get to that particular part of this chapter. Finally, with fluoroquinolones, it's simply changing the target. If you remember that fluoroquinolones inhibit an enzyme called topoisomerase II, when the bacteria changes that enzyme in such a way, the antibiotic can't bind effectively and it no longer works. We're going to start with our cell wall synthesis inhibitors. Again, this is the largest group of drugs because it includes all of the penicillins and all of the cephalosporins. The structure of these drugs is shown right here. What pens and cephs have in common is this four-membered beta-lactam ring. You see the arrow indicating that if you cleave this four-membered ring with the enzyme beta-lactamase, these drugs are not structurally intact any longer, and therefore they won't work. When you look at the branches for pens and cephs, you'll see the R group on the penicillins. We have a number of penicillins that have been developed, but they're all built off of this same basic nucleus. The same thing occurs for cephalosporins, except there's even more of these because we have a couple of R groups that are branch points where we can develop unique drugs. First, let's look at the mechanism for penicillins. The way that penicillins work is that they're going to be cell wall inhibitors. If you remember that the bacterial cell wall is a cross-linked polymer of polysaccharides and peptides, penicillins actually work by binding to penicillin-binding proteins, and they inhibit the transpeptidation reactions involved in cross-linking. And this is the final step in cell wall synthesis. By inhibiting this cross-linking step, the bacteria has a weaker cell wall that eventually can kill the organism. Now, a specific detail is that the beta-lactam ring that all penicillins contain can irreversibly inhibit the transpeptidase enzyme. In fact, these drugs are structurally similar to the D-ala-D-ala portion of the cell wall. And that's part of the mechanism why these drugs are going to bind and specifically inhibit transpeptidation. The three mechanisms of resistance that are listed on this slide we discussed in the previous table, but let's talk about them a little bit more here. When we use the term penicillinase, that's really referring to a type of beta-lactamase that can cleave penicillins. But beta-lactamase is a broader term, probably the more specific term that you want to use here because it refers to that whole family of enzymes that can cleave beta-lactam antibiotics. Changing PBPs means that you're changing the target for the penicillins. They can't bind effectively, and therefore they won't work as effectively. The third mechanism is preventing the entry of the penicillin into the bacteria by changing porins. You remember from microbiology that porins are important for gram-negative bacteria. So changing porins is a type of resistance mechanism against certain penicillins that work on gram-negatives only. When you think about other mechanisms of resistance, one of the things that we love to talk about is methicillin-resistant Staph aureus. When you think about methicillin-resistant Staph aureus, you want to ask yourself the question, how does that resistance develop? These are your choices. We'll discuss this on a later slide. When we look at our penicillins, we have 4 groups of these drugs. Similarly, we have 4 groups of cephalosporins, but we organize the cephalosporins into generations. We don't tend to use the word generation when it comes to penicillins, but you can actually think about them that way. And I'm going to organize them, in essence, into generations in another slide. So with our 4 groups of penicillins, let's consider the first group, which includes the drugs penicillin G and penicillin V. I would encourage you to make a statement about the spectrum of activity of each of these drugs, because you can organize your antibiotics by whether or not they're going to be narrow or broad spectrum. Narrow spectrum drugs, like these two, are only going to kill a subset of bacteria. In fact, what makes Pen G and Pen V narrow? They pretty much just work on gram-positive cocci, organisms like strep and even staph. However, when I think about staph, I'm really considering an anti-staph penicillin. So focus on Streptococcus as an organism that these drugs are going to work on. That could be Strep viridans, that could be Strep pyogenes, for example, but you'll notice I've also highlighted Treponema, the organism that causes syphilis, because Pen G is the drug of choice for syphilis. It's one of the very specific uses that you have to know for your exam on this drug. When you think about different STDs, your sexually transmitted diseases are very popular test questions. Make sure you know the drug of choice for each of the STDs. When you get the syphilis question, go with Pen G. Notice there's a statement on this slide that Pen G and Pen V are beta-lactamase sensitive. Out of the 4 groups of penicillins, 3 of them are beta-lactamase sensitive, which means if the organism produces beta-lactamase, the drug is going to be cleaved. Our second group of penicillins are commonly referred to as the anti-staph penicillins. It includes the drugs nafcillin, methicillin, and oxacillin. The label anti-staph penicillins is very accurate because that's what you're going to use these drugs for. They have a very narrow spectrum that includes staph. Now this is methicillin sensitive staph, not methicillin resistant. MRSA basically is a type of resistance mechanism where you get a cross resistance to all of the anti-staph drugs. So it has to be methicillin sensitive in order for drugs like nafcillin or oxacillin to be effective. You get staph skin infections or perhaps staph endocarditis questions on your exam. Make sure you notice this is the group of penicillins that are beta-lactamase resistant. It's the only group of penicillins that are not cleaved if the organism produces beta-lactamase enzymes, and that's a special property. Now, let's think about that case of MRSA. When you get methicillin-resistant Staph aureus, you know that the resistance is not due to beta-lactamase production. So how do you get resistance in the case of MRSA? Is it changing the PBPs or is it changing porins? Of course, it's modification of the PBPs because we're talking about a gram-positive organism here. In MRSA, the target has been modified such that the anti-staph penicillin does not bind effectively. So if I ask you to think about how do you kill MRSA, clearly the answer is with a drug that does not bind to PBPs. Our third group of penicillins are the broad-spectrum drugs amoxicillin and ampicillin. These drugs are beta-lactamase sensitive. They can be cleaved if the organism produces beta-lactamase enzymes. Now, broad-spectrum implies that not only will these drugs kill gram-positive organisms, but they begin to kill some gram-negatives. That's what makes them broad compared to the other two groups, which were narrow and very narrow. You'll notice some very specific organisms that we should highlight here, including listeria. The drug of choice for listeria is ampicillin, and listeria is a popular organism to ask a treatment question about. You also see otitis media questions on your exam. The most popular drug for otitis media is amoxicillin. It's because it's broad spectrum enough to kill all of the causative organisms. Enterococcus also occasionally shows up on the test. Enterococcus is killed by these drugs, especially by ampicillin. Our fourth group of penicillins are very broad spectrum anti-pseudomonal penicillins. The label anti-pseudomonal certainly reminds us that these drugs kill Pseudomonas, another very popular organism for a test question. But don't be misled by the title. Earlier, we had anti-staph penicillins, and what did they kill? They pretty much killed staph. The anti-pseudomonal penicillins, however, kill a lot more than just Pseudomonas. They're very broad spectrum, and that includes the drugs ticarcillin and piperacillin. What makes these very broad compared to the previous group, which were just broad? Well, this group has an expanded coverage against gram-negative organisms and especially gram-negative rods. So among the four groups of penicillins, the anti-pseudomonals are the broadest spectrum. They kill the widest variety of organisms, including gram-positive and gram-negative bacteria. I would encourage you to use this slide as a way to organize the penicillins, in essence, into generations. If you start with the very narrow spectrum anti-staph penicillins, then go to the narrow spectrum Pen-G and Pen-V. We then have broad spectrum ampicillin and amoxicillin, and the very broad spectrum anti-pseudomonal drugs. You've just organized your penicillins into increasing gram-negative coverage. You see, all penicillins have some ability to kill gram-positives. The more narrow their spectrum, the more likely it is that's all they're going to kill. But with the broad and the very broad spectrum penicillins, we get better and better gram-negative coverage, all the way down to the anti-pseudomonals, which have the broadest coverage of all because they kill so many gram-negative organisms. Some general properties of penicillins includes you can get enhanced activity if you combine them with beta-lactamase inhibitors like clavulanic acid or sulbactam. And if you think about why you would combine, let's say, a drug like amoxicillin with clavulanic acid, you would do that because you suspect that you're dealing with an organism that's producing beta-lactamase. Clavulanic acid would inhibit that enzyme and allow amoxicillin to kill the bacteria. Another combination would be if you added a penicillin together with an aminoglycoside. You would do this for synergy. Synergy is very important as a strategy against certain organisms, including Pseudomonas and Enterococcus. You could even throw Listeria into that group as a third organism that's very difficult to kill with just a penicillin alone. And most commonly, the drug you're going to add to the penicillin for synergy, aminoglycoside antibiotics like gentamicin. In the margin is a note, a bridge to biochemistry, about the action of these beta-lactamase inhibitors. Clavulanic acid, sulbactam, and a third drug called tazobactam are all what's called suicide inhibitors, which means they're going to irreversibly inhibit the beta-lactamase enzyme. They have such an effective action on this enzyme, it allows our penicillins to work even against organisms that are producing beta-lactamase. When we look at the pharmacokinetics for penicillins, like most antibiotics, they're eliminated by the kidney, and that means that you're going to have to do a dose reduction in major renal dysfunction. That's a rule for most antibiotics. For penicillin specifically, they are weak acids, so they're secreted by active tubular secretion in the proximal tubule. And this secretion is actually blocked by the gout drug probenecid. Perhaps another way to think about that is in the presence of probenecid, the penicillin will last longer in the body. It will stay in the blood because it's not being secreted as effectively. An exception to the rule that most antibiotics are eliminated by the kidney is with nafcillin and oxacillin, which are eliminated largely in the bile. It's a difference, but I don't necessarily think that this is a test question that's waiting for you. If you'll notice at the bottom of my slide, benzathine pen-G is a long-lasting form of this drug that has a half-life of about 2 weeks. It's this form that we specifically use in the treatment of syphilis. So remember, if you get the question on treponema, the most correct answer is benzathine pen-G, the repository form used for this organism. Easily the most popular side effect for a penicillin is hypersensitivity reactions. In fact, all types of hypersensitivity reactions can occur. That would include types 1, 2, 3, and 4. Anything from a mild rash to anaphylaxis could occur with a penicillin. And the type of reaction will predict whether or not we would ever consider giving that patient a penicillin or even a beta-lactam ever again. The incidence of hypersensitivity is around 5 to 7%, but certainly this is a side effect that you're expected to deal with on your exam. You want to assume complete cross-allergenicity between individual penicillins. So once the chart reads allergic to penicillin, pretty much you're going to avoid this group of drugs. In terms of other side effects, GI distress. Most antibiotics can cause GI upset. That would include nausea, vomiting, and diarrhea. Perhaps ampicillin is a little bit worse than the others for causing this effect. But again, I like to point out that is not a discriminating side effect. GI upset is very common for many of these drugs. The Yersh-Herxheimer reaction in the treatment of syphilis is basically a reaction that occurs due to the dying organisms. My clinical vignette reminds us that this starts about an hour after you begin treatment with benzathine pen-G. The patient experiences fever and muscle pains, and it's caused by cytokine release, but ultimately it's the reaction to the dying organism. Next, let's look at the cephalosporins. The good news is their mechanism of action and their resistance mechanisms are identical to penicillins. So once you've studied and learned the penicillins, you can apply those same mechanisms and resistance principles to this group of drugs. In fact, you can say it this way. All beta-lactams have the same mechanism, and they all have the same possible resistance mechanisms. So that's good news for you. Cephalosporins bind to penicillin-binding proteins. They inhibit those transpeptidation reactions involved in cross-linking. And resistance mechanisms include beta-lactamase production, changing the PBPs, or changing the porins to prevent entry. Cephalosporins come in 4 groups. In fact, we call them generations. When we think about the first generation drugs, these drugs are narrow spectrum. Just like we saw for Pen-G and Pen-V, which were also narrow spectrum, first generation cephalosporins don't kill a lot of organisms. So drugs like cefazolin and cephalexin are really good for gram-positive cocci. And they have very, very limited gram-negative coverage. So I think about them for strep and for staph. That would, of course, be methicillin-sensitive, not methicillin-resistant Staph aureus. There are so many cephalosporins, it's very difficult to remember them. We had a rule that we followed for a while, and that was if the drug has a pH in its name, it's a first-generation drug. In fact, that's the way that you can think about it. If you substitute the F with a pH, you can remember that first generations involve pHs in their name. Unfortunately, some of them also have an F, like cefazolin, and that's just one you're going to have to kind of file away. First-generation drugs don't enter the CNS, so I'm never going to consider them in a case of bacterial meningitis. Our second-generation drugs are broad spectrum. In fact, broad, as we've seen before, means we're going to get increased gram-negative coverage. Second-generation drugs still have some good gram-positive, but definitely expanded gram-negative coverage, including their ability to kill certain anaerobes. None of these drugs enter the CNS except for one, the drug cefuroxime. There are so many second-generation drugs. We list a few in our notes, and I'm going to give you my way to remember 3 of them specifically. If you look at the drugs cefaclor, cefoxitin, and cefuroxime, perhaps you can come up with a phrase that sounds like this. You can say it's a fact. Notice I've highlighted FAC for cefaclor, that I'm a foxy, FOX for cefoxitin, furry, well, I'm not sure about that, by the way, but cefuroxime, FUR, man. So you put it together, it's a fact that I'm a foxy, furry man. Now, for you ladies, if you want to personalize that, you can just simply change that and say it's a fact that I want a foxy, furry man. Or perhaps you can decide which of those properties you want and which ones you don't want. But that's a way to think about 3 of our second-generation drugs. By the way, which one of those second generations is the one that can get into the CNS? That's right, the one that can go where the fur is, the furry drug. Our third-generation cephalosporins are very broad spectrum. Again, we've used this terminology before. What that means is their gram-negative coverage is even more expanded compared to the second generation. They still have gram-positive coverage, but definite effects on gram-negative cocci and gram-negative rods. There are a lot of drugs here in third generation. Let's pick out a few, including ceftriaxone and cefotaxime. Notice I've highlighted the ax part of their name. That's important. It's a way to remember that you can easily recognize those as third-generation drugs. Cefixime or cefdinir. Perhaps you can remember those 4 drugs with a phrase that says, use your axe to fix a 3-course dinner. So axe, fix, and DINIR as parts of the names perhaps you can remember. In fact, let's go back and focus on the ax part of ceftriaxone and cefotaxime. And maybe another way is to remember that the ax drugs are very effective for meningitis. People remember ax to the head for meningitis. These are very effective drugs because the third generations, most all of them, enter the CNS effectively. So the treatment of meningitis, bacterial meningitis, with these third generation drugs. Ceftriaxone is also the drug of choice for gonorrhea, another one of our STDs that you have to know how to treat. So when I think about third generations, very broad spectrum, but some very specific organisms and diseases that I've highlighted on this slide that will be important. We only have one fourth generation drug, the drug cefepime. In fact, the fourth generation drug is very similar to the third generation in that it's very broad spectrum. Kills gram positives, kills a lot of gram negatives. In fact, it can even enter the CNS. If we compare third and fourth generations even further, we find both groups are beta-lactamase resistant. So let's put it all together. When it comes to the 4 generations of cephalosporins, First and second generation drugs are beta-lactamase sensitive. If the organism is producing beta-lactamase, chances are good the drug will be cleaved and be ineffective. But third and fourth generation drugs are beta-lactamase resistant. So therefore, we can either change the PBPs as a mechanism of resistance, or we can change the porins for those gram-negative organisms as a way to develop resistance to third and fourth generation. When we look at the pharmacokinetics of cephalosporins, very similar to penicillins, they're eliminated by the kidneys. They're also weak acids, so they're actively secreted in the proximal tubule. That secretion is blocked by the gout drug probenecid. Same story that we told earlier for penicillins. You expect to adjust the dose of cephalosporins in renal dysfunction. There's one major exception that you need to know. It's the drug ceftriaxone, which is eliminated in the bile. My clinical vignette reminds us that you should avoid ceftriaxone in neonates. It's because neonates cannot metabolize this drug effectively. You get decreased biliary metabolism that can result in biliary sludging. So stay away from ceftriaxone. In fact, maybe this phrase will help you. The phrase is, don't try axing neonates, only adults. The side effects of cephalosporins are very similar to penicillins, and it includes hypersensitivity reactions. Even though the incidence is slightly lower, all ranges of hypersensitivity reactions can occur. Once again, rashes all the way to anaphylaxis. You want to assume complete cross-allergenicity between individual cephalosporins, but there is partial cross-reaction if you're allergic to penicillins, around 5%. A good rule to follow is this. In a patient who had a previous rash to a penicillin, most often we put those patients on cephalosporins for their infection. But if you had anaphylaxis to a penicillin, you want to avoid all beta-lactam drugs because their chances of cross-reacting are actually higher in that case. In the margin is a note called Classic Clue. It reminds us about certain organisms that no cephalosporin can kill. And the mnemonic is lame. Kind of like if a cephalosporin can't kill it, it's lame. The mnemonic stands for listeria, atypical bacteria like chlamydia or mycoplasma, MRSA, and enterococcus. None of our cephalosporins kill those organisms. The one, however, that I think has a great chance of showing up on your test and is related to this point is listeria. My clinical vignette about meningitis reminds us that in certain cases, listeria can be a causative organism. You remember that listeria is a cause of meningitis at the extremes of life. The very young or the very old get this organism as a cause of their meningitis. It can also happen in immunocompromised patients. So special populations can get listeria meningitis. But we cannot use a cephalosporin all by itself in those cases because the cephalosporin won't kill listeria. So what drug do you add to the regimen to ensure that you have coverage for listeria? You add ampicillin in the case of neonatal meningitis, meningitis in the elderly, or in immunocompromised populations. Of course, your choice of cephalosporin would include the AXE drugs, ceftriaxone or cefotaxime. And we've just covered that if it's a neonate, you don't want to go with ceftriaxone, go with cefotaxime. We're still thinking about cell wall drugs, and of course we're still covering beta-lactams when we look at imipenem and meropenem. I've highlighted the ending of these drugs' names because penem has become a family name. We have about 4 of these drugs out now. All beta-lactams have the same mechanism, so the penicillins, the cephalosporins, and the penems all bind to PBPs. The resistance mechanisms are also similar, except these drugs are resistant to beta-lactamases. So changing the PBPs or modifying the porins are ways that you can get resistance to the penems. These drugs are very, very broad spectrum. In fact, they're the broadest spectrum antibiotics that we have. They kill almost everything. So what would such a very, very broad spectrum drug be useful for? The answer is empiric therapy. You have a patient come into the hospital with a severe, life-threatening infection, but you don't know what it is. Starting that patient on a penem is a very good strategy because chances are good that it will kill the causative organism. Certainly you can put them on these antibiotics while you get culture results and decide specifically what type of organism you're dealing with, and you can always then switch to a more narrow spectrum drug. Among the penems, imipenem is special because it has to be given in combination with the drug called cilastatin. Cilastatin is a renal dehydropeptidase inhibitor, and by using this drug, you prevent imipenem from being metabolized to a nephrotoxic metabolite. To emphasize that and say it a different way, if you give imipenem all by itself, it's nephrotoxic. So cilastatin is not an antibiotic. It's simply there to prevent the formation of this toxic metabolite. The other penems can be given by themselves. So we don't have to combine meropenem or any other penem with cilastatin. Imipenem is the one that's different. Some of you may also notice the spelling of the word cilastatin. The fact that it ends in statin is a little bit concerning, because when we see statin, we think about HMG-CoA reductase inhibitors, drugs that are excellent for lowering your total cholesterol. Cilastatin, however, is not an HMG-CoA reductase inhibitor. And the way that I've always remembered that is if you make a little play on the beginning of its name, you can say silly statin, not a statin. It's not one of those HMG-CoA reductase inhibitors. When we look at the side effects for the penems, GI distress, which is common to most antibiotics, some cross-reactivity if you're allergic to penicillins, but watch out for seizures on overdose or in patients with renal dysfunction. And this is a very popular question with the drug imipenem. If you give imipenem to a patient with normal renal function, the risk of seizures is very low. However, if the patient has renal dysfunction, that's when the plasma levels of imipenem can increase to a level that might result in seizures. If you're thinking, why would I ever give this drug to somebody who has renal dysfunction? That's probably not the scenario. The scenario is the patient had normal renal function, but over time as you were treating them, there was a decline in renal function. And without adjusting the dose, that can result in toxicity. The last of our beta-lactam antibiotics is aztreonam. This is a drug, like all beta-lactams, that binds to PBPs, inhibits the transpeptidation reactions involved in cross-linking. The resistance mechanisms are very similar to the other beta-lactams, but this drug is resistant to beta-lactamases. It has a very interesting spectrum in that aztreonam only kills gram-negative rods. So the resistance to this drug most likely occurs because you're modifying the porins. It's gram-negative organisms after all. I think the most outstanding feature of this drug, though, is it's the only beta-lactam that does not cross-react if you're allergic to penicillins or cephalosporins. All other beta-lactams have some level of cross-allergenicity, but not this one. The next drug we're going to cover is vancomycin. I want to make sure everybody understands we're still talking about cell wall drugs, but we're no longer talking about beta-lactams, because vancomycin is not a beta-lactam antibiotic, which importantly means it does not bind to PBPs. It has a different target. So the mechanism of action of this drug involves binding to the d-alla-d-alla-muramyl pentapeptide. It's going to inhibit the transglycosylation reactions involved in elongation of peptidoglycan chains. And this is an earlier step in cell wall synthesis than where the beta-lactams are going to work. Many people overestimate the spectrum of vancomycin, I believe. Vancomycin is a great drug, but it just really works on gram-positive organisms. In fact, that's a good summary. Vancomycin is a great drug for serious gram-positive infections. When you think about MRSA, the more serious form of this organism is hospital-acquired MRSA, and that's the setting where you're most likely to use vancomycin. We have other options for community-acquired MRSA that we'll discuss at a later time. Enterococcal infections are treated by vancomycin, but once again, only if it's a more serious infection. Milder enterococcal infections can be treated by ampicillin. How about Clostridium difficile? Vancomycin used to be the drug of choice for this organism, but now it's a backup drug. And the drug of choice is metronidazole. So really only in cases where metronidazole doesn't work or cannot be used would you consider vancomycin for C. diff. Definitely the resistance of vancomycin is a popular test question. We are starting to see vancomycin-resistant staph and vancomycin-resistant enterococcal infections. So watch out for VRSA or VREF, vancomycin-resistant E. faecium. The resistance mechanism involves changing the target, which has been very popular so far as a resistance mechanism. If we change the D-ALA to a D-lactate, the bacteria develops resistance to vancomycin. You've modified the target in such a way that the drug can no longer bind. Make sure you know that mechanism of resistance. In terms of kinetics, we give vancomycin IV. That's because it's not absorbed orally. But there is one situation where you would take this drug orally, and that's if you're using it to kill C. diff. It's okay to take it orally, even if it's not absorbed, when your goal is to kill a gut bacteria. It does enter most tissues, but doesn't effectively go into the CNS related to its large size, and it is eliminated by the kidneys. When it comes to the side effects of vancomycin, red man syndrome makes for a very good question. Red man syndrome is a flushing reaction caused by histamine release. The flushing occurs in the head, the neck, the upper torso. It's an upper body flush that we call red man syndrome. And it actually happens because you have infused the drug too rapidly. The recommendation is to give vancomycin as a slow IV infusion over at least an hour to avoid this flushing effect. The other side effects of ototoxicity and nephrotoxicity. While those sound kind of scary, they're very unlikely to occur if you're only using vancomycin. But what if you're using vancomycin along with another drug which has these same side effects? You should be thinking about aminoglycoside antibiotics. Aminoglycosides have both nephro and ototoxicity as side effects. If you're also thinking, why would I ever combine vancomycin with an aminoglycoside? It's because of spectrum. Vancomycin is excellent for gram-positive organisms, and aminoglycosides are excellent for gram-negatives. So that combination would give you broad spectrum coverage, but unfortunately would increase your risk of these side effects.